Okay, I think we'll go ahead and get started. I'd like to welcome everybody to the third edition of the IGCS COVID-19 Virtual Tumor Board Series. I'm Joe Ng. I'm a GYN oncologist from the National University Cancer Institute in Singapore. And I'd like to welcome all our participants. We're up to 79 participants right now, and I'm sure more will continue to filter in. I'd like to introduce the two main panelists, two main presenters for today's tumor board. And they are Dr. Onyinye Balogun, who is a radiation oncologist joining us from Weill Cornell, and Dr. Michael Pearl, who's a GYN oncologist and palliative care specialist joining us from Stony Brook Medicine. We've got a very distinguished panel as well joining us. We have Dr. David Atallah, who's a GYN oncologist joining us from Beirut, Dr. Benjamin Elly, GYN oncologist from Kenya, Diceyn Scroggins, who is our IGCS Director of Global Outreach and Engagement and an ovarian cancer survivor herself, and Professor Alexey Shevhuk is joining us from Moscow. So, and I understand that we have participants signed up to join us from 52 countries, and so across several time zones. So wherever you are in the world, good morning, good afternoon, good evening, and for me it's good night. So without further ado, I will go through the session outline. And the session outlines are going to be case presentations with panel discussions. The discussions will be kept just to the panel, but there will be a moderated QA discussion at the end of all the presentations, and we will make sure that we'll get to most of your questions. Now, there is a live QA feature on this call, and we welcome you to send your questions, which will be curated and moderated as well during the session. Just some housekeeping tips, housekeeping matters on echo etiquette. Only the panelists will be the ones speaking during the presentation. Attendees' microphones will be muted. If for whatever reason your microphone is unmuted, we kindly ask that you mute your microphone to make sure that the recording continues to be smooth. This will be recorded, and the recording will be available on the IGCS website after today's session. So if you found today's session useful, please make sure to share the fact that the recording is available on the IGCS website. Our first presenter is Dr. Onyinye Balogun, again, a radiation oncologist from Weill Cornell in New York. She'll be presenting two cases. And without further ado, Oni.
Thank you. Thank you, Joseph, Dr. Ng. So I just want to remind all the participants that the Project ECHO case consultations do not create or establish a provider-patient relationship between any IGCS volunteer clinician and any patient whose case is being presented in a Project ECHO setting. The responsibility for the patient remains with the medical team who is caring for that patient at their institution. All right, so the first case is an 82-year-old woman who presented to our institution in Brooklyn, New York with a left labia lump. It had been there growing for about 4 months, then it stabilized in size for the next 8 months. She began to notice bleeding from this bump, which led her to seek medical care. Her past medical history included hypertension and hypothyroidism, and she'd previously undergone a complete thyroidectomy. She was a current smoker. On physical exam, an approximately 6 centimeter vulvar mass on the left labia minora was noted that was within 5 millimeters of the anus. Shoddy nodes were palpated in the left groin. Vulvar biopsy was performed and revealed a P16 positive invasive squamous cell carcinoma that was also positive for high-risk HPV, although not for subtype 16, 18, and 45. She subsequently underwent PET-CT in February 2020, which revealed a 4.1 by 1.5 centimeter irregular soft tissue mass that was extending posteriorly into the gluteal fold with an SUV ranging from 11.2 to 18. In addition, there was mild hypermetabolic activity in the left groin, corresponding to a borderline enlarged left inguinal lymph node. There was otherwise no pelvic or inguinal lymphadenopathy. Surprisingly, the PET-CT also revealed a 1.1 centimeter right upper lobe lesion with FDG activity. There were also small scattered pulmonary nodules that were below the resolution of PET imaging, a 3 millimeter left upper lobe and a 3 millimeter right lower lobe nodule. Emphysematous changes were noted, but there was no mediastinal or hilar lymphadenopathy. She underwent CT-guided biopsy of this lung lesion in order to rule out metastasis versus lung primary. And it turned out that this was in fact a primary lung adenocarcinoma. After discussion at multidisciplinary tumor board of her case, a woman with concurrent stage 2 vulvar cancer, as well as stage 1 non-small cell lung cancer, as well as discussion with the patient, we opted to proceed first with treatment of the right upper lobe lesion. So just a week before the onset or the start date for her radiation therapy, all non-essential businesses were closed in New York due to the pandemic. We had a discussion between the patient's providers, as well as the patient and herself and her family regarding the potential risks and benefits of proceeding with treatment. They opted to proceed with treatment, and we started by giving her 10 gray times 5 using stereotactic body radiation therapy to the right upper lobe lesion. Although she was slated to begin treatment with radiation therapy on the 13th of April, she called our office on the day of her proposed start in order to delay treatment because she was not feeling well. 6 days later, she was admitted due to severe shortness of breath at home. Upon arrival at the hospital, her oxygen saturation was at 84% on room air. She was placed on a non-rebreather, and her oxygen saturation rose to 94%. She was tested for SARS-CoV-2, and the test returned positive. So questions for this case include, when is it reasonable to begin cancer-directed treatment for her vulvar cancer? We have had limited evidence published regarding cancer patients with coronavirus, and there is limited evidence that suggests the patients who have non-small cell lung cancer may be the most vulnerable to death. In the series reported by UJ et al., there were 12 cancer patients who had coronavirus. Out of those 12, 7 of them had non-small cell lung cancer, and 5 of them were on active treatment, whereas 2 had a history of non-small cell lung cancer. The other question is there any role for just radiation therapy alone? Although we were planning to give chemoradiation, is the risk of chemoradiation potentially higher than radiation therapy alone due to the setting of coronavirus?
Onyinye, thank you so much for that wonderful presentation. I think that's a lot of good, thought-provoking points. I'd like to start with David. David in Beirut, and I'd like your thoughts on this case and what you think might be some key discussion points.
It is a really unusual case, having 2 cancers. First, in the lung, there were scattered lesions, 3 millimeters scattered lesions. You considered it as not metastasis, or that because you considered it stage 1 lung cancer?
So we reviewed her case with radiology in our multidisciplinary tumor board, and they felt that those were not really suspicious lesions. They did not look consistent with a pattern of spread. They were just kind of 3 discrete lesions that could be due to airway impaction. So we favored a diagnosis of stage 1 non-small cell lung cancer.
Okay. Considering stage 1, everybody knows actually with the history of all the pandemics and the actual history of in China and the CDC from China, patients having cancer have a double risk of mortality, not only lung cancer. And we know that even patients cured from cancer have more risk of having complications and intensive care admission. So this patient is at high risk of dying from COVID. And the problem of vulvar cancer becomes obsolete in front of this question. So I think that we must focus on her COVID now, actually. And we try to treat her for her COVID. And as soon as she is recovered from that, her stage 2 vulvar cancer can be treated. Fortunately, she had a treatment, a complete treatment, 50 grays on her upper right lung tumor, if I'm correct. So now we have to focus on her vulvar cancer after being treated from COVID, because she has forcedly a deadly disease. That's my opinion.
That's a really good point, David. I think Benjamin, you had a question?
Thank you for the opportunity. Thank you, Joseph. This is a very interesting case, mainly because she has 2 cancers. My question is she really stage 2 or stage 3? Because you mentioned there were nodes that were present and in the inguinal, in the inguinofemoral. I mean, the short inguinal nodes, if I may use that word. Were they just clinically palpable nodes, or they were actually positive for disease? That will put us stage 3. And then my other issue is that we are from an emerging economy, and we don't have really the luxury of radiation. So I would look at this case with the lens of where we are operating from. Probably would have given her chemotherapy in the absence of radiation for her vulval cancer. However, I agree that her immediate threat is actually COVID, not the vulval cancer.
Alexey, would you like to, I'd like your thoughts on what you think about chemotherapy in a COVID positive patient.
In our country today, we decide not to provide chemotherapy in case of in cases of COVID patients, and usually we have to wait for recovery, and after this we recommend it to continue with treatment. In this case, I know that the last NCCN guidelines on this type of lung cancer, according to these guidelines, it is allowed to postpone treatment on the lung cancer for several months. And in this case, I think the treatment of choice will be radiation therapy alone, without chemo.
And I think just to wrap up, I'd like Michael's thoughts on, and maybe Diceyn jump in as well, on you know, the triaging of care in a patient that's got multiple malignancies and COVID as well.
Yeah, so I was listening with fascination to the discussion. I guess it's my role to take everybody a step back and look at the 30,000-foot view. Here we have an 82-year-old woman with 2 separate malignancies, as well as somebody who is quite ill from COVID. She's on a non-rebreather at 6 liters and just barely able to keep a minimal oxygenation. So if we take a very giant step back, her likelihood of succumbing to COVID is far greater than her likelihood of succumbing to either one of her malignancies in the near future. And as I'll talk about, or at least bring up for discussion, as far as resource allocation, this is one of those circumstances where resource allocation would be needed very carefully. You know, you have to have a very careful discussion about that. So personally, if she were my patient to handle, I would have a very in-depth, frank discussion with her about goals of care, It's unlikely that we're going to completely cure her cancers, even in the best of circumstances. And then when you throw COVID in as an overlay, she's far more likely to succumb to that.
That's the, yeah, Diceyn?
Just really briefly, I just think it's important that particularly during this time, during COVID-19, that we remember that patients don't have that 30,000-foot view. It's
Right.
very intimate and very personal for them, so that we have to be sure, and I'm sure, you know, Michael, you and I have talked before, and I'm sure that you have that perspective, but all of us across the world in really different settings have to be aware of that when we have these conversations, and be very, very honest in terms of the autonomy, what are the possibilities, and not make people think they can do things they cannot.
Yeah, that's a really important point, and I'll bring that up again as I get into my portion of this, kind of the conflict between patient autonomy and social justice.
Yeah, wonderful discussion. And I just want to remind everybody who's, all the participants that are on the call, that you can post questions live. There's a live QA, and our QA curators are standing by. They're itching, they're waiting for your questions. Without further ado, Onyinye, I think we'd like to hear about your second case. Go ahead.
All right, the second case involves a 51-year-old woman who has multiple comorbidities, including HIV, on antiretrovirals, hepatitis C, and cirrhosis. She underwent, in January of this year, she had vaginal bleeding and was sent for blood work, which revealed a hemoglobin of 4.9, essentially microcytic anemia and thrombocytopenia. She underwent an ultrasound as well as endometrial biopsy that revealed endometrioid adenocarcinoma with focal clear cell component. The next day, MRI of the abdomen and pelvis again revealed an abnormally thickened endometrium measuring over 2.3 centimeters in thickness. There was also abnormal soft tissue extending into the cervical canal and abnormal enhancement in the parametrial region. There was no ascites or lymphadenopathy. So this is the MRI that was performed, showing the thickened endometrium as well as the mass protruding into the cervical canal. On physical exam, she had actually stopped bleeding at the time that I saw her, and there were no vaginal lesions. We discussed her in our multidisciplinary tumor board, and given that she had a performance status of about 1, she didn't have any neurologic sequelae due to cirrhosis, and she did want treatment. We decided to attempt to treat her as a medically inoperable endometrial cancer patient. So she began her treatment prior to the pandemic and continued to come in regularly in order to receive radiation therapy to her pelvic nodes, her uterus, and her vagina. As treatment went on, she seemed to improve. Her labs showed that her hemoglobin was rising and her platelets were also stabilizing. And then the COVID-19 pandemic was declared about halfway through her treatment. So we had initially thought perhaps we can do neoadjuvant radiation therapy and then take her to the operating room to really try and give her the best chance of taking care of this disease. But as we neared the completion of external beam radiation therapy, her hemoglobin dropped again to 4.8 and her platelets down to 48,000. So now the question is, what boost technique should we use for this patient? She, despite all her comorbidities, she continues to live on her own, come to clinic regularly, is motivated to complete her treatment. We would like to pursue brachytherapy, which is usually given to medically inoperable patients. However, the safety of it and the limited resources, given that our surgical operating rooms have been minimized in terms of our access to them. On a case-by-case basis, they do allow us to do cases, and we have advocated on her behalf, but is brachytherapy the best thing to use, or are there any alternatives such as SBRT for this woman?
Great. I think we have a question from the audience. Just a quick question, Oni. Did this patient have a chest CT or any kind of assessment of, or maybe a PET for systemic disease?
Yes, so she did not have any evidence, because in someone like this, you don't want to be too aggressive it would be futile. So she did not have any distant disease.
Great. So I'm going to pose this question to the panelists as well, because I know the Onyinye had asked questions about RT. I don't know. We'll go around the panel to ask what everybody thinks about hormone therapy. Michael, maybe you can.
Okay. Michael?
Yeah, so yeah, that was my thought as she was presenting. So first off, the radiation question. Our institution, because we're in New York, has the same restrictions as you do. But on a case-by-case basis, they are allowing us to do cases. And this might be one of the cases where we would be allowed to bring her in and do the procedure. And if we had the technical capability, and I have to check my radiation oncologist, it might be one where we would go back to low dose rate to minimize the number of times that she would be in and out of the operating room. So that's one. And then if that's not feasible, or even if it is feasible, then I think adding a hormone therapy would be very reasonable as a palliative treatment. Remember, you're not going to overall cure, you might be able to keep her disease under control, but she has other medical conditions that are ultimately going to cause her to die. So your goal is to keep her comfortable from her endometrial cancer.
I'd like to pose a question to the other panelists as well, and maybe we'll start with Benjamin as well. How long do you think it would be a reasonable interval to prolong or delay definitive treatment for this patient? Again, I think this goes to endometrial cancer patients. I think the audience is we're getting quite a few questions from the audience, because I think obviously because endometrial cancer is a fairly common cancer, and a lot of audience members are seeing endometrial cancer patients, and they're wondering how long they think they can reasonably delay treatment. So Benjamin, what do you think?
Yeah, thank you for the question. One, like I said, that I may answer this question with the background of where we are working in an area where radiotherapy is not readily acceptable. I would first want to know about the hormone receptor status of the endometrial biopsy, because that would guide us into how long we can actually wait. Because if the patient is estrogen receptor positive, then probably we can use hormone treatment. If it's hormone receptor negative, then it may mean that we may have to intervene much sooner.
Good point. David?
In fact, for endometrial cancer, there are many reports showing, and the webinars showing that the most sensitive to delay are early endometrial cancer and the low-risk endometrial cancer. If you consider her as eventually an early endometrial cancer, so with no invasion, no lymph nodes, and no invasion, so practically we have to operate on this lady. And if we are in a low setting, in a low prevalence, like here in my country, a low prevalence of COVID, fortunately we have a low prevalence of COVID, we can manage, provided this patient is COVID negative, we can manage eventually to do an intervention. The problem here is her platelets that are very low, and trying to operate on either by spinal anesthesia or general anesthesia, it's a little bit tricky. So the data on brachytherapy are data on cervical cancer, not on endometrial cancer, because we are actually extrapolating from cervical cancer data. So endometrial cancer is a surgical case. It's a surgical disease we have to operate on. So giving SBRT has to be done when you cannot give brachytherapy. when
So David, I'm going to
brachytherapy is
interrupt
not-
here. So you're suggesting surgery would be your first line treatment, and it's what you're recommending?
If the setting allows, because to give her a chance for that.
Sure. I think we had a question from the audience, Oni, about why your thoughts on why this patient might be thrombocytopenic.
Yeah, so it turns out that she may have, there's a condition that she has whereby she has a hemolytic anemia. So that's the blood side of it. The thrombocytopenia, we think maybe it could be due to her her cirrhotic disease. We're just not quite sure what's going on with that picture. Of course, we wanted to make sure with her history of cirrhosis that she isn't bleeding from her, from any esophageal varices. She has had endoscopies in the past, but never had any intervention or any sighting of a large varix. And she doesn't have any melena or bright red blood. So it could be the liver disease. It could be other factors. We're just not quite sure.
Yeah, I think that those are all interesting discussions. In Singapore right now, we're having discussions about low-grade endometrials and starting temporizing them with hormone therapy before the situation allows us to, the elective situation improves. Because again, our elective situation with regards to surgery is kind of, it's exactly as Michael pointed out, it's difficult to get an OR slot. So I think without further ado, we're running right on time. I'd like to keep things on time. And Oni, thank you very much for two very, very interesting and thought-provoking cases. And I'm sure the questions will continue to roll in about those, which we'll address at the end. I'd like to hand the mic over to Michael and have him present his case and his didactics. Michael?
Sure. Let me just get to... So just as an introduction, I practice on Long Island in New York, in the United States. We're one of the COVID hotspots, New York, obviously, and Long Island as a whole. As of a couple of days ago, when I pulled up the slides, New York had almost 250,000 cases that were confirmed. Obviously, the true number is going to be substantially higher than that, and we had about 18,000 deaths. Here on Long Island, we had about 30,000 cases and 930 deaths. This was several days ago, so those numbers have obviously gone up. My institution is a COVID hotspot. We've been shut down basically except for most of the COVID issues. So I was asked to provide a gynecologic oncology consult for a person under investigation for COVID-19. And on findings, she appeared to have advanced gynecologic malignancies. I'll show you in a second. So when she presented to the emergency room, 77-year-old postmenopausal Caucasian woman, she'd had a worsening cough and shortness of breath for 2 to 3 days, associated with nausea and vomiting for 2 to 3 weeks, bloating, epigastric pain, alternating diarrhea, constipation, and a small weight gain over the previous 6 weeks. She denied a fever, chills, chest pain, bleeding, or any ill contacts. She initially presented to her nephrologist, at which time she had abdominal distension with a palpable mass, decreased breath sounds on the right, and appeared to be in atrial fibrillation. So she was advised to go to the emergency department immediately. Patients are sequestered in the emergency room these days given COVID. Her past medical history is significant for a renal cell carcinoma for which she was treated surgically in 1996 in neoadjuvant therapy. She has chronic kidney disease and her creatinine normally runs about 1.75. She also has high output heart failure, type 2 diabetes with hemoglobin A1C that's typically in the 6s, and she has reflux. She's on a variety of medications for her medical conditions, and then coincidentally or unfortunately, she's allergic to azithromycin. She was a non-smoker. She denied alcohol or drug abuse or any pertinent family history, and her remaining systems review was non-contributory. We are not allowed, given the COVID crisis, we are not allowed to come into the emergency room except for true emergencies. So the patients are seen by the emergency room staff and then discussed with us virtually. So she was an alert white woman in no acute distress. You can see her vital signs on the screen. The important thing was that she was a little bit tachycardic. She was mildly tachypnic, and her O2 saturation on room air was poor at 89%. Decreased breath sounds and dullness over the right lung. She had abdominal distension, shifting dullness with a fluid wave. She had a palpable, firm mid-abdominal mass that was not tender, and she had no rebound tenderness or guarding. And because she was seen by the ED staff, they did not perform a pelvic or rectal examination. Her pertinent laboratory results are listed here on the screen. She was mildly anemic. She appeared malnourished with low protein and albumin. And then her COVID labs are listed here. Her LDH was elevated. Her D-dimer was very elevated. C-reactive protein was mildly elevated. Her procalcitonin was minimally elevated. And then she had some electrolyte imbalances. Her creatinine was higher than it is for her baseline. Her glucose was, her hemoglobin A1C was about normal. She was screened for COVID. And at the time that I was asked to provide the consultation, it was pending. And her CA125 was elevated as expected. Here's our CT scan that was done through the emergency room. It was non-contrast based upon her elevated creatinine. She had a large right pleural effusion. She had ascites, endometrial cake, peritoneal carcinomatosis, unable to clearly see her uterus or her ovaries. And then she had a number of sclerotic bony abnormalities, the etiology of which was indeterminate. There's cross sections on her CT scan showing her ascites and carcinomatosis, and then deep down in her pelvis also showing carcinomatosis without clear delineation of her gynecologic organs. So her initial management, our COVID patients are those who are persons under investigation or admitted to a medicine service, and we are not allowed to enter the room. She was admitted on telemetry and found to have sinus tachycardia. She was on precautions and isolation, started on low dose or low flow oxygen, given fluids, her electrolytes were adjusted, and her medications were adjusted based upon her acute kidney injury. And then arrangements were made for her to undergo a CT guided biopsy, thoracentesis, and paracentesis by interventional radiology. We could call, but we were not allowed to go into the room. The rooms do not have windows, so I was unable to physically see her. And unfortunately, she was one of the patients who did not have access to an electronic device that would allow video conferencing. Here's the results. As anticipated, everything came back with high-grade serous type carcinoma favoring ovarian or peritoneal origin, and the immunohistochemistries were consistent. So it didn't look good. She appeared to have stage 4 high-grade serous carcinoma of Mullerian origin, either ovary, primary peritoneal, or fallopian tube. So the issues that I would like to bring up for discussion, I think all of us who are GYN oncologists are very familiar with managing patients such as her. And if she presented on an average day prior to the COVID crisis, this would be bread and butter in essence for almost all of us. But now in the COVID issue or the COVID epidemic time, this is no longer just bread and butter. Yes, the discussion about you have stage 4 cancer of the ovary and how to manage that, I think we could probably all do without breaking a sweat. But when we overlay COVID, now everything changes significantly. And so how do we break the news to a patient such as this? And in my circumstance, how do I have a discussion with her over the telephone where I've never met her? This was my first interaction with her, and I can't even see her, and she can't see me. I can't examine her. I can't go into the room. So the ethical questions I have is how to perform a consult in these circumstances. How do we manage these patients? And then what is the resource utilization? So I'll throw these out just as a stimulation for discussion. As we all know, the ethical principles that underlie medicine, in no particular order, except these are kind of the order that most people will evaluate them, is patient autonomy, beneficence, or otherwise known as do good for the patient, non-maleficence, which is our Hippocratic oath, do no harm, justice, meaning treat people equally, and veracity, which is tell people the truth. The application, obviously, of each of these and combination of these is very complex. So patient autonomy is patient self-determination, and in a general circumstance, certainly prior to the COVID pandemic, patients had a near absolute right to refuse all recommendations, and that right mostly remains intact, although, as I think you'll hear, is no longer fully intact. And it does not entail an obligation on our part to grant any or all requests for continued therapy. And I think this is where the COVID epidemic has created a conflict and a sense of moral distress. Beneficence is promoting the health and welfare of the patient. So we're obligated to do what is best for the patient. And that requires us, as Darcy had mentioned, it's our obligation to take the 30,000 foot view and remember that our patient is our patient, but we also still fit within the overall community. Non-maleficence is out of the Hippocratic Oath, first do no harm. So in this circumstance, doing no harm may prohibit the provision of therapy that carries substantial side effects with no probable benefit. And as Vivian von Gruningen and her staff wrote, medical futility are treatments that serve no physiologic, quantitative, or qualitative purpose. Justice, this is the big one at the moment. Justice is treating patients fairly, but patients may be defined both individually, that's our responsibility for our individual patients, but also on a global level. And by global now, we mean truly global, not just within our own community. We're using resources for therapy that serves no meaningful purpose, medically futile, denies access to those resources for others who might derive benefit. So if I use up a set of PPE to go in and have a conversation with this woman about her stage 4 cancer of the ovary, for which in the best of circumstances, her 5-year survival is less than 10%, and I use up a set of PPE that otherwise might have been used by a nurse who could go in and take care of a patient who is on a non-rebreather and might survive his or her COVID, I've committed an ethical assault upon justice. And then veracity is our obligation to tell the truth, and this has not changed. It's our obligation to tell the truth as best we know the truth, and the lack of honesty, even if we mean well, robs patients and their families of opportunities to make an informed choice. And if you don't tell the truth and somebody finds out, it jeopardizes the foundation of our relationship with our patients and whomever else. So I will leave you with this and then open it up to discussion. Remember that death is a natural, inevitable end to life. Our responsibility is to assist patients and help them achieve the appropriate and easy passage to death. It does not mean we kill them, but as they're dying, we can help. And it's one of the most important and rewarding services that we can provide. So I will stop there. And I think I've left the requested 20 minutes for discussion.
Thank you very much, Michael, for the very thought-provoking presentation. It's always a pleasure to hear you speak. So I think we've got plenty of time for questions, which is how this was designed to work, and I'm glad I managed to keep this train on the tracks. So we're going to clarify some questions from the audience regarding the second case, the endometrial cancer case. Onyinye, and correct me if I'm wrong, but I think there was evidence of parametrial and cervical involvement in this patient as well. Is that correct?
Yes, there was. So it wasn't just within the endometrium. There was abnormal enhancement in the parametrium as well as the mass in the cervical canal. And I think someone had a question about
how much do you think that figured into the decision not to take her to the operating theater, besides her other comorbidities?
I think our surgeons feel comfortable, operating, even if there is that extensive disease. But the main consideration was that she was had a lot of thrombocytopenia. She was thrombocytopenic, she was anemic, and even though her performance status improved as we treated her and her vaginal bleeding stopped, at the time she did not look like someone who would leave the OR without severe complications.
Right. Because I think I had a question from the audience about the possibility of transfusion or factor transfusion and surgery. Was that considered?
So in general, she had lowish levels of thrombocytopenia. I think just overall, this picture of cirrhosis, the picture of, HIV, which at the time was not greatly controlled, but she has gotten better. Just sometimes lack of medical compliance. In general, we just wanted to see if we could, rather than subject her to potential complications down the line, she seemed more motivated to coming in for radiation, which proved our point. She was okay with coming in for the radiation therapy, and she came in, but at the time, it just did not seem like taking her to the operating room, that it would have been enough to just give her transfusions and take her.
Right. I had a question for the panel in general. I'd like to hear everybody's thoughts on high dose or high potency progestin therapy in patients that are sick. What your experience is, and how well that's worked for you in your experience. David.
Yes, we use it for fertility sparing endometrial cancer. So it works, and we use it for some cases like this patient when we are not going to operate on, and it may reduce significantly the bleeding. It may be an option, but I think it has to be the last option to do. If we can offer this patient something more radical, I think we have to do it, even though she has AIDS or cirrhosis. But if she's going to die from bleeding, we have to do something for this bleeding and address this question promptly.
Alexey, and in Moscow, are you finding that for your endometrial cancer patients, you're doing a lot more hormone therapy to delay surgery, or are you not an issue at all?
Thank you. I think that hormonal therapy can be an option for this patient, but usually these patients with such disease, with such advanced disease, they are usually at risk of huge bleeding. And this is a question that we have to think about it. I think that in our clinic we will do everything to make the prophylaxis of this bleeding, and the hormonal therapy for these patients can be an option. But I agree with Onyinye that this is not a candidate for the surgery at this time, at the time of COVID era, because she can face a lot of severe complications related to the surgery. Thank you.
And Alexey, I had a follow-up question on ethics at the institution where you're at. Do you think that the current situation with COVID has changed medical ethics and the practice of medical ethics in Russia and in Moscow specifically?
Thank you for this question. To date, this situation hasn't changed any treatment practice in Russia. But I have to say that in Russia, we are, I think, at our way to plateau, and we have only 74,000 cases all over the Russia, and about half of these are in Moscow region. What change we have done? Every patient in our clinic is testing. We perform express testing for COVID, and so we do not attend to patients with positive COVID. It is allows us to perform treatment without any change for the patients now. But I think the situation will change in the future, and the lecture of Michael was very interesting related to this.
And Diceyn, do you have any? Do you have an opinion or something to say about, you know, palliative care and patient autonomy in the age of COVID?
I do. I have to tell you, as I sit here, as a cancer survivor, the mother of a daughter who has metastatic cancer, a sister who is under treatment right now, getting chemo and undergoing precautions, you know, friends who are being treated, and in a member of a community that's disproportionately affected by COVID. There's a tightness in my stomach. I'm stressed. I'm stressed listening to this, listening to what I consider to be a real challenge to ethical principles right now, and a challenge to how we practice it, and somewhat how we have to compromise on particular things. This idea of autonomy, wonderful, but when you come into a room and you don't come into a room and you're sort of looking through a keyhole, or you're not seeing a person's face at all, and you're trying to deliver information as well as receive information, you know, that's really difficult, because in part, because of comorbidities, because of other things that enter the picture, because of this social justice thing, which is generally thought to be the good of the public or the good of the masses, you may have already, the decision might be made. I mean, we can have all the discussions we want, and we can say we're having joint, decision making and so on. And then you think about it on the palliative care end of it in general, you know, in the best of times, most patients don't receive true palliative care. Only, you know, the World Health Organization has found that about 14% in the world, about 14% of the people who need palliative care get it. So think what they're getting now. It's not an extra, it's not a luxury, but it's something that people are not getting. So this has me sitting here literally, and when I say this, I mean it. You can probably hear it in my voice. It's just, it's a very, very difficult time. And I think that patients have worries that you can't even imagine, and concerns that are absolutely valid. And it's very difficult to address them when you're in the middle of this whole pandemic.
And you're touching on a point that I think it's resonating with the audience as well, which is that as a patient, I'm going to ask this question to you, Diceyn, from a patient's perspective, and have Michael jump in as well as a palliative care provider. How important do you think is the human touch? I mean, like, a lot of our consultations are going to be virtual right now by virtue of requirements, right? And it's just, how important is that human connection, sitting in that same room?
I think it is humongously important. I mean, that's probably not a real word. I think it's just, it's more important than I can actually, you know, define or can tell you here. I think it's important. In touch, you know, sometimes we have to decide that since we can't physically touch now, that is part of a healthcare team, we need to find ways to make sure that people understand how important they as an individual are. I know that we're talking about, you know, the social justice as making sure that we don't provide services to one that's not going to be meaningful and deny services to others. But we have to make sure in our voice, in the things that we say, in the choices that we make, in the questions that we ask, that we are making sure that people understand that they individually are still important to us. Excuse me. I think that's important, both in terms of whatever the length, aside from the mortality end of this, the morbidity end of it, how people go away feeling about it, what their last moments might be, because for some people, these conversations will be a part of their last moments. I think that high touch part of it is absolutely essential. And I think that's what's getting lost. And I think it's painful to think about. To me, it's really painful to think about.
So, yeah, so the quick answer to that, and then I have a little bit more expanded answer to that. So the quick answer is I agree wholeheartedly with Diceyn. I think that listen, there's Zoom fatigue, right? You know, we're all feeling it, where normally we would sit in a room and see somebody, and we could interact not just by looking at, you know, somebody's head and shoulders on a video screen. And that's just in normal conversations like this one, let alone where we're faced with a life and death, you know, one of the most important discussions that a patient may have. So I think that the lack of touch, the lack of physical contact, the lack of being in contact with somebody is something that we're all feeling, not just in medicine, but as we're all socially isolated. So that's one issue. And then if I can expand upon that to a larger issue, and this is for us as healthcare providers, is that one of the things that is happening is where this crisis has created moral distress on our part. You know, we're faced with having to make those decisions where our responsibility has been to our individual patient or patients. And yes, we were all part of a global community, but now that global community is threatening to take precedence. And in institutions such as mine and the others across New York and other places in the world where there is truly, where COVID has become the major factor, that global community and the pressure to function within that global community and make the global community the primary responsibility threatens our ability to take care of our patient. And because we're all who we are, and because we do what we do because of who we are, and our belief is that our responsibilities to our individual patient, that creates an internal moral conflict within us as healthcare providers. And that creates this sense of distress. And so as we wind down these conversations, one of the things that I would urge everybody to take away is remember that you're part of this picture too. And you're a resource. From a global community perspective, you're a very limited resource, just as much as a PPE component, a mask, a set of gloves, or a mat or a gown. You're it. And so it's incumbent upon all of us to pay attention to that stress that Diceyn just talked about, that has to develop. It does develop within all of us, and to figure out a way so that you can balance that stress and to be able to work. And then remember that your responsibility still is to your patient and your patient and your patient. And yes, it's overlaid by COVID, so that as we have discussions with our patients, so for example, the patient I presented in her consult, what I ended up doing was, the initial discussion was, you know what, I'm really sorry that I can't see you. And I'm very sorry that I can't be in the room where we can sit and have a conversation and you can't see me. But times are tough. And these are the realities of life at the moment. So if you allow me to accept that, then let's move on, and we're going to talk about your newly diagnosed cancer. And so we had a full discussion about our newly diagnosed cancer. And then at the very end, or the last segment, as I was talking about management options, you don't have to do anything about this. You can have neoadjuvant chemotherapy with interval surgery. You can have surgery with adjuvant chemotherapy. You can go on hospice. You can go someplace else. Not really, but you can go someplace else. As I was presenting those management options to her, now COVID came into place. So instead of telling her that, look, you could have cytoreductive surgery followed by adjuvant chemotherapy, I said, in general, that's an option, but at the current circumstances, that is no longer an option. And so back to Diceyn's comment about patients losing some autonomy, at that circumstance, she lost autonomy. That is no longer an option for her. It is not an option. And so she's lost autonomy. But that's still ethical because it falls within social justice. It just creates a potentially a controversy within ourselves. And fortunately, we have alternatives. And then just to give some closure on this patient, because there is closure on this patient, we had multiple discussions over the telephone, both while she was in the hospital, COVID positive, ultimately did okay, went home. And she ultimately decided not to do anything for her cancer and is enrolled in an outpatient hospice. But I think she would have done that independent of COVID. It just created another layer. So
And
don't
I think that,
yeah, sorry, Joe.
no, Michael, and I think that raises a really interesting question, which I'd like to kind of put around the panel. And that question is, how do you, in your own practice, balance the needs of the many versus the needs of the few, right? So again, the COVID, like being resources for COVID and making sure that you comply with requirements for you to conserve resources for COVID patients versus that patient that's sitting in front of you. I mean, how do you deal with that? That would be my question. And on my screen, I'm going to go around and Benjamin, I'd like to hear from you first as the most newly minted GYN oncologist in the group.
Well, thank you, Joseph. Our situation is different because we're in the fifth week of the pandemic, and we have 343 confirmed cases, out of which we have quite a number of recoveries and 14 deaths. So in our practice, it has not changed much. The only thing that has changed is that we have stopped doing electives, but we are running clinics as normally. We are running chemotherapy units as normal. So the only issue is about doing elective surgeries. Otherwise, everything else is running normally. Of course, you have to take the precautions of PPAs amongst other protective measures that have been instituted.
David, do you have an opinion on like only treating patients with good prognoses? I mean, like, you know, now more than ever, right? Because, you know, we're in a situation where some of us may be forced to make that difficult calculus, right? Which of the patients get treatment?
Forcedly, a patient treated in a low setting where the COVID is not anymore peaking. It's not like treating it in New York where we have these dreadful figures, and forcedly they are forced to trump personal justice to social justice. But fortunately, I think it is a very important question, and the answer will be case by case. And in patients where really we are in front of life saving, we don't have to ask a question. But when we are in a situation like New York, it is the right way to do, as they have done. I think I fully agree with them. And it's a very hard decision to take. I understand, Michael. It's really a very hard decision to take.
Alexey, do you have a view on this? I'd like to hear from you.
I think it is very difficult for me to make any comments because we still haven't faced this situation like New York, and I hope it will not be in our country. But I think all this situation with COVID changed our philosophy and changed our relation with the patients and our opinion about our treatment. So I think in our country now we treat all the patients. We do not make any choice, treat or not to treat, because we do not have this tragedy like at New York. But I don't know now what will be in the nearest future.
And I think it's been a very, very interesting discussion. I think that's this particular tumor board has left us with a lot to think about, not only individually, but as a community and in service of our patients. And I think that's the importance of these platforms, which is to exchange information, to continue talking, and to keep the discussion open, because none of us have the answers. I mean, let's face it. I mean, this is unprecedented in our lifetimes, and you know, we're all making our way, you know, forward with the best way we can, right? And the only thing that we can rely on is each other. And this is wonderful that we have this platform. And I'd like to thank all the panelists for a wonderful discussion and for a wonderful tumor board, and all the participants for joining us. Please continue to join us every week. Tell your friends, community, get your teams on board as well, because again, the only way we're going to get through this is together. And this is why the IGCS was put together, and this is why we're here. I think it's an existential. This is existential mode for the IGCS, and like I said, none of this would have been possible without the support of the IGCS staff. I'd like to thank Mary Eichen, again, the CEO, for support, Kathy Fearing, membership director, Mandy Hansen, our online manager for online education, and certainly Susan Ralph, who supports me and the team for the mentorship and training committee. I'd like to, again, with closing notes, again, the series will continue monthly. Again, these recordings are available on the IGCS website within 24 hours. There is a COVID-19 resource and discussion forum available that's ongoing on the website. And of course, the newest addition to our armamentarium is the COVID-19 survey. This is an IGCS survey that's been put out to all members to try and understand how they're practicing GYN oncology and caring for women with cancer in this difficult time. Please go on, please take note of the survey link. Please give us your input. We'd like to hear from you, how best the society can support you, and how as a community we can do this together. Thank you once again for joining us for the 3rd edition of the IGCS COVID Tumor Board. Join us again in the next series for series 4. Thank you again. And from where I am, good night, everybody. Thank you.